Gastroenterology. I'm the director of the Food Allergy Institute and the division chief for Pediatric Allergy, and he's going to give us a talk on updates in food allergy.
Thanks, Maya. Thanks for the invitation. I did think for a few seconds about, well, food allergy from a pediatrician for a bunch of GI docs. What is that all about? But I'm going to imagine that you guys do get in the office setting some issues with this, and so hopefully it will be very relevant. So these are just some disclosures, and this is nothing really that will be relevant for this talk. These are my learning objectives, and Dr. Shahade isn't necessarily one of the learning objectives, but the point is that I'm going to be talking about evaluating food allergy, about the diagnostic tests that we use and that are available out there and how they've changed over time, and also our current approach to treatment and prevention, which is actually also significantly changing and has changed over the past few years. I'm not going to be discussing eosinophilic esophagitis. That's the reason Dr. Shahade's picture is there, because I'm sure she hasn't already spoken to you about it. She can speak to you about it at another date. So an important part about food allergy is the epidemiology, both the perceived epidemiology among patients and also the real epidemiology of it, which is how many people actually have what we would define as a food allergy. And part of that is, how do we define a food allergy? So if you just ask people on the street, are you avoiding a food because of a food allergy, you could get numbers like 20, 30, even 40% in some groups. And that's because people will just use a blanket term of food allergy for any adverse problem that they might have with foods. But if you really start to apply some diagnostic methods and some more specific definitions that I'll get to, then you get to be more in the 6 to 8% range for children. And we usually were saying the 3 to 4% range for adults, but there was just a study out in the last few months that seemed to use pretty good methods and was saying that in adults, about 10% have real food allergy. And even in the field, we kind of are wondering whether that's real or not. There was a national study, and it did apply some decent methods to make the diagnosis. So there may have been an increase, and more of our patients, including adult patients, might be affected. When we're talking about what foods trigger the real food allergies, for kids, it's milk, egg, wheat, soy, peanut, tuna, fish, and shellfish. Yes, I've mentioned that to audiences before, so I can say it pretty quickly. In adults, the ones that stick around and affect adults more are fish, shellfish, and then there's a whole bunch of fruit and vegetable allergies that are usually not severe, but are pretty common. And I'll get to that as well and give you some examples. So what is the story in terms of defining a food allergy? Because I mentioned already that a patient might say, hey, I'm allergic, I can't have this or that, but they might be in a different category than an allergy. So at the bottom of the slide here, allergy is really defined as an adverse immune response to the food. And so that's really what distinguishes it from other adverse responses. Now, there could be some things that overlap, like scromboid fish poisoning. So if you've ever gotten fish in the cafeteria here, you're pretty high risk of having fish poisoning. But the scromboid poisoning, which is the dark meat fish, actually releases histamine-like chemicals that cause what looks like an allergic reaction, but it's really a food poisoning. Lactose intolerance, lactase deficiency, you guys are very familiar with, and so a patient might say that's a food allergy, but obviously it's a totally different scenario. Among the allergic responses, we sort of divide the scenario of pathophysiology in IgE antibody-mediated reactions, which are typically quick on onset, the anaphylactic ones that we're familiar with, and then non-IgE or cell-mediated responses, which tend to be more chronic in nature and also include more of the gastrointestinal responses that we see. So this is a very cartoonish look at the mechanisms, but our immune system absolutely sees what we eat. It sees the proteins in our foods. It makes immune responses to those food proteins, but not in an adverse way. And why is that? The immune system has a lot of work to do figuring out, bad actors, bacteria, viruses that might come into the system, good bacteria not to attack, and then all these food proteins, thousands and thousands of different ones that are safe. But there are immune responses to them. IgG, for example, is produced. But when things go wrong, you can have more of an allergic response, which may include an eosinophilic response with chronic inflammation. It may include an IgE response with processing of antigen results in plasma cells making IgE that finds its way to the surface of effector cells like mast cells and tissues and basophils in the bloodstream. There are high affinity IgE receptors that will get populated with the antibodies that might be specific for a variety of things in allergy, like cat allergy, so cat dander proteins, whether it's pollen or in this case food proteins. After the system is armed and dangerous, if someone ingests the food again, the IgE antibodies that are specific for that food will be cross-linked, signals will be transduced from receptors, and then you're going to have release of mediators immediately, like histamine, that will cause allergic responses. So the mechanism of reactivity, whether it's antibody-mediated or cell-mediated, along with the different parts of the body that can be affected, ends up in giving us a spectrum of food allergic disorders or symptoms that I have displayed here from the left on IgE-mediated reactions that could affect different parts of the body with hives or abdominal symptoms or respiratory symptoms or systemic reactions like anaphylaxis. Or on the right, a number of disorders that I'll get to a little bit later. I won't be talking about celiac, but enterocolitis, enteropathy, and proctocolitis, which are basically kid diseases, but I'll give you some examples of others. In the middle, we have disorders where we see some IgE, but we think maybe the cellular system is more active. And so this includes the eosinophilic gut diseases and also atopic dermatitis or eczema. So let's consider a typical patient allergic response, like what I get a telephone call about. This is a 21-year-old who has asthma. They ate a walnut bakery cookie. 2 minutes into eating it, their mouth is itchy. 5 minutes later, they have hives. 10 minutes later, the lips swollen, they're hoarse. If they call you on the phone, you'd be saying, get to an emergency room because you're probably having an anaphylactic reaction. So after things have settled down, we're going to consider how do you diagnose what caused that reaction. But just off the bat, thinking about what was eaten here, what do you think the reaction was caused by? Walnuts, because that would be a common allergen that would cause severe reactions. So what is anaphylaxis? Back in 2006, not 2006, they got a group of experts together for 4 days to wrestle with a definition of anaphylaxis, and they came up with this, pretty simple, one sentence. Anaphylaxis is a serious allergic reaction that's rapid onset and may cause death. So then I spent some good money to figure that one out. But it really just points out that it's a clinical diagnosis. There isn't like a lab test that you do that says, oh, this is anaphylaxis. The symptoms of anaphylaxis can include severe ones, which kind of characterize it, which are listed here. But there are also mild symptoms, and sometimes we'll treat for anaphylaxis technically, even if there aren't more severe symptoms happening, to prevent progression to a more severe reaction. And that confuses people sometimes because we're telling them to go ahead and treat their allergic reaction with epinephrine, the key treatment for anaphylaxis, even if maybe they aren't like suffering with severe breathing problems. There are more causes of anaphylaxis than just food, so we always keep an open mind if there has been an episode of anaphylaxis, like when that person was eating the walnut cookie, were they outside and the yellow jacket was on the cookie and they actually got a sting in the mouth or something like that. But of course, we're familiar with allergic reactions from drugs, biologics, and a variety of other triggers. There are also things that can look like an allergic reaction that we have to keep in mind. I already mentioned that scromboid fish poisoning, which can look like anaphylaxis, but even panic attacks can look like anaphylaxis and other either respiratory or cardiovascular events. The common causes, again, so I mentioned before the triggers for kids: milk, egg, wheat, soy, peanut, tree nut, fish, shellfish. For adults, peanut, tree nut, fish, shellfish, and fruits and things like that. But the strong triggers of a more severe reaction fall into that group of peanuts and tree nuts and fish and shellfish, probably for reasons that have to do with how the proteins themselves get into the circulation and are more stable through digestion. But we also have had deaths from anaphylaxis, for example, to milk. And you can have severe anaphylaxis to almost any food. We think about the time course of anaphylaxis for a few reasons that have clinical implications. Usually the reaction starts within minutes of ingesting the food, but it can occur even an hour or two out. The symptoms can progress at different rates. They may again affect different parts of the body, but sometimes after treatment it quiets down and then it looks like everything's okay, but then symptoms start to kick up again an hour or 2 hours later, and that's called a biphasic reaction. Sometimes even a longer delay will happen. Sometimes anaphylaxis can happen without skin symptoms, which could be tricky because you're kind of expecting, well, allergic reactions should have hives, but that's not always the case. And actually in fatal anaphylaxis, there are many cases where there's no hives, and that's probably because it was under-recognized as anaphylaxis and therefore under-treated and then ended up with a fatality. So let's go back to this case. the 21-year-old with asthma had the walnut bakery cookie and had this reaction. So what would we want to know and do? Perfect. That's a great question. Because if he said, well, I was eating walnuts yesterday and nothing happened, it's kind of bizarre to have a severe allergic reaction the next day if you're already tolerant of that food. And that's probably one of the reasons why we see more of these types of reactions in adults, where they're not eating necessarily shrimp that often or a specific tree nut that often. So the bakery cookie ingredients are important as well. And so it had walnut and egg and wheat and sugar. And getting back to your question, there's a history of allergic issues, which goes along with someone who's prone to an anaphylactic reaction. He doesn't frequently ingest tree nuts. So that's ooh, probably was the walnut. And if we wanted to confirm this allergy, there are a number of tests that we could do that actually use the pathophysiology that I showed you earlier. And the common one that I'm sure you've heard of is the prick skin test or scratch test. And this test is a pretty simple idea. You have the skin. I think I point, yes. So in the upper left, there's one of the devices. Here we have some other devices on the lower right that can just scratch and extract into the surface of the skin. So they'll make an extract, let's say, of walnut protein, and then scratch it onto the skin. It'll seep in. So the cartoon I have at the bottom is back to those mast cells that I had in the earlier cartoon. They're armed with IgE antibodies. So you scratch the surface of the skin, the walnut seeps in, meets the IgE. There's local release of histamine if possible, and then you get this wheel and flare response. So that's not a nipple on the upper right, it's a hive. And so in the area where the scratch is, you get this bump and redness around it from an axonal reflex. And we measure that. So the bigger it is, probably the more IgE response there is. So the person has to be off of antihistamines for this test. We do a histamine control, which is positive, a saltwater control, which is negative in most people. And we measure the size. But a very significant point with all this is that there are people who make antibodies that we could detect with a skin test or a blood test, as I'm about to show you, but they could eat the food anyway. So if I just go to the park right here and I test everybody for peanut, 10% will test positive. Obviously 10% of people don't have peanut allergy. So this is not, as I tell my patients, a pregnancy test. Yes, no, it's more of a statistical test. The stronger the response, the more likely there's an allergy. But if you have pre-test probability that's high, like I ate a walnut and had anaphylaxis, and you have a positive test, you've pretty much confirmed the diagnosis.
Do you check for dermatographic before you do this test?
So that's what the salient, good question. And I know this audience has no problem with interrupting, so feel free to do it. Good. So that's what the saltwater control was for. That was for the dermatographism. Because you're right, and we would have to subtract that type of response from the other responses if we want to continue. And some people are so dermatographic, they get a response just from being scratched, that we can't even use the test. So this is the test that's easier to catch for you guys. You could send a blood test for IgE antibodies to a whole bunch of stuff that's out there. In fact, the company that makes this test would love for you to order panels of 50 or 100 tests at $35 a pop. So they like that. But basically how this works, it often has been called the RAST test. That's probably the familiar term for it, kind of a leftover term. RAST stands for radioallergosorbent test, so radioactivity, they don't use that anymore. It's a fluorescent antibody test now. But let's watch the cartoon at the upper left. So we have a solid matrix, like a gel, that has embedded in it, in this case, walnut proteins, like a conglomeration of walnut proteins. And so you're in the test tube, you put the serum in, and if you have IgE antibodies, they're going to attach to the protein of walnut, and then you put in a secondary antibody that's labeled, so a fluorescent labeled antibody that's the anti-human IgE antibody, the IgG antibody, anti-human IgE, and then you could measure the glow in the dark, and you could quantify that. And so we get back units or classes. Mostly now we're seeing units per liter or Ku per liter. So it's giving you, again, a quantitative result. And again, like the skin test, it's not the pregnancy test. So the stronger the positive, the more likely it's an issue. But again, just like going into the park for peanut allergy, you're going to see a lot of positives when the person might have been able to eat it anyway. So the history is very important. The pretest probability is very important. So just to summarize, you have a food, let's say it's egg. You have the positive skin test, and you might expect a clinical reaction. But there's more to the story. You could have people who are sensitized, and they can have their cake and eat it too. They're okay, and you have to think why. And some of the reasons are that I have on the left lower, different amounts of antibodies. So that has to do with the robustness of the response. Different affinity. So how sticky is that antibody to the protein? Different binding patterns. So, a protein's got a lot of amino acids, a lot of shape to it. Where is it binding? How many areas on the protein? Binding to labile proteins. I'm going to get into this more, but if a protein breaks down in digestion, it's not actually so important. You might be able to pick it up on the skin, but when you digest it, it doesn't get to the bloodstream in the same way. And not on the list, there is also the effector cell activity. So, like, how robust is that mast cell response? So this is a cartoon view of what I've been saying, that the bigger the skin test or the higher the Ig level, the more likely it is that there's really an allergy. But this cartoon curve varies by the food, by the age of the patient, by the specific diagnosis. So there's a lot that goes into this, and it's not like you can't really look up, like you could look up like a cholesterol level, what the ranges might implicate, but you can't really do that for these food allergy tests. Sometimes a negative test, you still have a reaction anyway. It's maybe 5–10%. So we always do pay a lot of attention to the history, and we might say, gee, we need to do yet another test to just make sure whether we're correct or not. So one of the things that's changed in the field is something called molecular or component-based diagnosis, and that goes back to my comment before that a food is many proteins. So walnut is not one protein, and depending on what proteins that are being seen in the walnut, there could be different clinical implications of that. And that's, again, goes back to the robustness of the protein and binding, and the amount of the protein and the digestive ability against that protein getting into the bloodstream. So if we take a food like peanut, there are characterized proteins in it, particularly RH1, 2, and 3, that are troublemaker proteins. These are more resistant to digestion. They get into the bloodstream and they could cause anaphylaxis. If you have IgE against those, you're in more trouble than if you have IgE against RH8, which breaks down easily and actually is related to pollen proteins. And there are other proteins that have different implications. So the tests now are starting to tease out the proteins. And so this is just a list of some of the available ones where we can look at the robustness of the response against the more troublemaker proteins versus the ones that are more innocent and come to a better diagnosis. So let's get back to that cookie incident. So blood tests were done and someone checked off a panel, which we don't like to happen, but happens. And there were some tests done to all of the foods that were in that cookie, including egg, wheat, which was the highest number, and the walnut was negative. So what kind of questions might we ask or think about now? It's not matching our expectation. We expected a positive to walnut. So great. Whoops. They don't. They don't. They eat wheat all the time, and that goes back to go in the park and test people who are eating peanut to peanut. 10% are testing positive. So it shouldn't have been tested. Same thing for egg. But there's something else that's tricky about this. It was a bakery cookie, and so bakeries use other ingredients. And even though it was a walnut cookie, the bakery does use other nuts, and certainly it could have gotten another nut to that cookie. And it turned out that cashew was really the trigger. And cashew is pretty well known as being a very significant allergen. It's a very potent allergen. It's actually, many people will classify it as more potent than peanut that we hear about all the time. So for what it's worth, this person was actually reactive to cashew. So if we're not sure about an allergy, we do the proof is in the pudding test, and we feed the person the food under medical supervision. The very fancy term we use for that is oral food challenge. And the most scientific version of a feeding test or oral food challenge is a double-blind placebo-controlled food challenge, where I have a dietitian in the back room who'll make up a mixture of things, and one of the feedings has peanut in it, for example, another feeding doesn't, but they taste and look alike, and I and my nurse, and we're taking care of the patient don't know what they're eating at any given time. We start with a small amount, gradually increase. We might do that 2 separate days, one with and one without the test food, let's call it peanut. And that's the research method that we use. But in clinic, we're usually just openly feeding the person the food, and they might freak out, which having a panic attack is an issue, and we have to think about that. We might go back to hiding the food. So once we've made the diagnosis, in this patient it was a cashew allergy, we're going to talk to them about management. And that includes things like recognizing an allergic reaction and knowing how to treat it. It means teaching them about medications to use. It means teaching them about how to avoid the food, which is actually pretty complicated and takes up a lot of our counseling time, because now you think about, well, gee, restaurants and, parties and every social event having to do with food, so it's a big deal. Epinephrine is the primary treatment for a severe allergic reaction. We tell people to use it promptly. There are a number of different auto-injectors. The two that are most common are on the top there. There's a generic as well of this EpiPen, which is like the people usually you need an EpiPen. It's been around for a long time, so people use almost like they say, hey, you need a name, but it's epinephrine and an auto-injector. So the way this works is you make a fist around the device. It has an injection in it. There's different doses for kids versus adults, but the adult one is a regular EpiPen. There's a lock, so this unlocks it. It gets pressed into the lateral thigh firmly. It'll click. You count to 3, 1, 2, 3. See, it's not that painful. I'm jazzed up, but I already had coffee, so I'm okay. When you take it away, you don't see a needle sticking out, and so that's that. This other device is kind of like the iPhone version of the auto-injector. It looks a little bit different, but it talks.
This trainer contains no needle or drug.
Unfortunately, it talks too long, so I'm not going to listen to the whole thing, but it basically talks the person through using it. They don't have to listen to the whole thing, but this is what it...
You are ready to use. Pull red safety guard down and off of please black end against outer thigh. Then push firmly until you hear a click and hiss sound.
How much does that cost?
1.
You want to buy one just for the fun of it? So it actually depends on where you're trying to buy it. So the company is fighting with the other company. So you could find these for like $700 if you go to the wrong place. But insurance will cover it, and it'll be like a copay of $30, and the company's got it like a mail order pharmacy for it. So we give our children patients a written action plan. We encourage medical identification jewelry, and we really teach them to use this promptly at the first sign that symptoms are progressing. So let's move to another case. This is a woman who has, I call produce problems, 35-year-old, gets itchy mouth with a number of fresh fruits and vegetables. She has hay fever. The foods that bother her are apple, peach, and cantaloupe. If we skin tested her using fresh extracts of these foods, they're positive. They make extracts for us to test with that are not like fresh extracts, so they're sitting around a while, and those might be negative. So this is a sort of a cocktail party diagnosis because it's so common. 10 to 20% of adults have this. Does anyone know what it is? We call it oral allergy syndrome or pollen food-related syndrome. And so the underscored thing, which isn't underscored, would be hay fever. So if you have allergic rhinitis or hay fever, that's what gets this kicked up. So it's more of a contact allergy in the mouth. It's uncommon for this to cause severe reactions. The protein that triggers the start of this would be, for example, birch pollen protein. So you get allergic in the nose, you might get sneezing and itchy nose and maybe asthma also. The pollen comes out March, April, May. Ragweed is another common one, comes out in like August, September. So you start off with making IgE antibody to the pollen, but unfortunately or fortunately, Mother Nature has put the same exact protein that's in the pollen into a lot of different foods. And they're listed here, like birch is related to a bunch of the rock fruits, ragweed to the melons. So let's say, for example, you have birch pollen protein allergy, you make IgE to a part of that protein. The apple protein is different, but it has homologous areas, and it's going to catch the same IgE. So you wouldn't lick your car clean of pollen, but if you did, your mouth would be itchy. When you bite into the apple, your mouth gets itchy. There's a lot of variability with this. So washing the apple doesn't matter. It's not pollen on the apple. Peeling it might help because of the protein being concentrated more near the peel, but heating it helps because this breaks down easily with digestion or with temperature. So the same person I mentioned before doesn't have a problem with apple juice, only with raw apple. We don't usually cook melons, so that's a different thing. So here's another case. This is a 38-year-old who likes to run. She has a salad, she runs, and then she develops anaphylaxis. And the skin test was positive to celery, but negative to the other ingredients in the salad. And she says, I eat celery, so I've never had a problem with it. Why are you telling me now I'm allergic to celery? But this is a little bit different. Does anyone recognize what this is? So this is food-associated exercise-induced anaphylaxis. And so this person indeed can eat celery and they're fine, they can exercise and they're fine, but if they eat the celery and then exercise, they have anaphylaxis. Wheat and shellfish are other common causes of this. It probably has to do with how these are absorbed. Again, a digestion issue, but there's change in blood flow to the gut during exercise, and that might be part of the story. People have looked at looking at proteins in the bloodstream during exercise or not, and seen some differences there as well. And that may be why certain foods fall into this category. There are other augmentation factors that might make you react to a food that you're eating at other times without a problem, or if you're already known to be allergic to it, might make the reaction worse. And this includes not just the exercise, but viral illnesses. So, I mean, you know, you're getting sick and then suddenly you're reacting to something you weren't reacting to before. Use of nonsteroidal anti-inflammatories, again, probably brings the protein in more quickly into the bloodstream. Alcohol, same thing. And for reasons we're not exactly sure, menstruation also. And that usually only affects women. So a lot of times people are, well, I'm allergic to this. Do I have to worry about everything that's related to it? And so the answer is sometimes. So peanut allergy, which is pretty common, maybe 2% of the population now. Do I have to worry about beans? Because peanut's a bean, it's not a nut. And only about 5% of people with peanut allergy have a problem with other beans. Tree nuts, it depends on the tree nut, because they kind of pair up, like hazel and almond are similar to each other, walnut and pecan are similar to each other, cashew and pistachio are similar to each other, but not to others. So it kind of depends. With fish, there's a pretty high rate of cross-reactivity, but yeah, we do see some people who are just allergic to swordfish and nothing else. With grains, it's a pretty low rate of reaction. I skipped shellfish, shrimp, lobster, crab, crustacean shellfish, high rate of cross-reactivity. With milk allergy, which you don't see as much in adults because they usually have outgrown it if they had it as children, if you're very reactive to milk, beef could be an issue. Comes from a cow, has some of the leftover proteins, and most mammalian milks are a problem. So sheep, goat, and such. Mare's milk is usually less of a problem, but they don't like to be milked too much. So here's a fairly common scenario that comes up. 68-year-old has complaints of weakness, joint aches, headaches, and wonders if food allergy was a cause. So remember the definitions. Previous allergy evaluation, blood was sent for IgG4 IgE analysis to 192 foods with a lot of positives. Do you see IgG testing? Does that come up?
Yes.
So, you know, there is some literature on it with irritable bowel and things like that, but as I mentioned earlier, making IgG is actually normal. And so you could have a test that's built to measure it, and you're going to see people have positives. And you could have companies that decide to make 10-page colorful brochures associated with what your test results are and tell you not to eat those foods, but there's not science behind that. So this person ended up restricting their diet, losing weight. They shouldn't be losing weight, and if we did do a regular allergy evaluation, which we probably shouldn't, it would be negative because these are symptoms that have nothing to do with IgE, have nothing to do with food allergy, essentially. Although I guess you could come up with certain angles on that. So there are a bunch of unproven and experimental diagnostic tests. So professional organizations write papers and call these like not recommended, experimental, unproven. They don't typically use the word quackery. I think it's because of lawsuit issues, but that probably could be used as well. So provocation neutralization, you know, so this is done here in New York by some practitioners. For a child, the mother would hold the child, hold a jar or vial that has the food, and then the doctor checks to see how strong the other arm is, and if the mother is weak, then that food is a problem for the child. If the mother is strong, it's not. And that sounds crazy, but that demonstration is so straightforward. Like, listen to me talking for 15 minutes about all of the nuances of a skin test. So, you know, so here's this one person saying to them, "Ooh, your child should stop having egg with the terrible eczema because you're weak." And then I'm going, "Well, the IgE level is 2.3 and the skin test is 5, and there's like a 50% chance that egg is a problem. And we're going to have to bring you in and clear your skin up and then do a food challenge and then see if there's a symptom. And, oh, there was one, but maybe it was," you know, so it's easier to do this. But anyway, so cytotoxic testing, they throw the food into with your cells and decide whether the cells are popping or not. And then the listen method, which is what this brochure was about, which mentions that it's not FDA approved, but we who use it find it to be helpful. They hook you up to electrodes and figure out how much resistance is going through your body while you either touch, taste, or eat different foods. So this is interesting stuff, but we don't really rely on it. So I promised you before that I would talk a little bit about non-IgE mediated reactions. And I promised you I wasn't going to talk about eosinophilic esophagitis, but on the left-hand side, we have a syndrome called food protein-induced enterocolitis syndrome. This is classically described in babies who will ingest a food and then 2 hours after eating it have severe repetitive vomiting. They may later have diarrhea. Their white count shoots up in the left shift. They're often thought just to have some kind of sepsis thing going on, end up in an ER getting a sepsis workup, which is negative, and the family says, you know, I had given 2 hours before for the first time, and they're like, that's stupid. No, just something else wouldn't happen. And then they go home and they give it a second time, and then the same thing happens, and they come back and go, this is the second time I gave oat, and the same terrible thing happened. The kids could get actually methemoglobinemia, they get acidosis, they can look pretty shocky and lethargic and yucky. Milk, soy, rice, and oat are the most common triggers of this. Again, with this 2 hour delay response, I think it's primarily an innate immune system issue, cell-mediated response. There are some chronic forms where the baby is on the food and chronically is having failure to thrive. Probably a different illness on the right-hand side is the mucousy bloody stools that often breastfed babies get, maybe associated with maternal ingestion of food getting passed to the baby through the breast milk and then triggering a eosinophilic colitis kind of response. We'll have the mother alter her diet. A lot of times that may actually be a viral infection and we're just like spinning our wheels and changing diets for no reason. But in the middle, we have an enteropathy, kind of like a celiac disease, not from gluten. This has not really been in the literature for about 15, 20 years at this point. And maybe we were talking about eosinophilic gastroenteropathies and people were thinking differently then. But the EpiPens has also been increasingly described in adults. And when it has been described in adults, it's mostly been shellfish. And so here are some case series and reports of adults who ingest the food and 2 hours later have this repetitive vomiting. They have negative skin tests and they can get pretty sickly. So if you're seeing that and it's just like, sounds like a weird thing, it might be real. And again, they get these high moit counts. So there's stuff going on systemically. So the good news for kids with food allergies, most will outgrow it, although not all. So we follow especially for outgrowing of milk, egg, wheat, soy. It's harder to outgrow peanut, tree nut, fish, and shellfish. More adults have that. The GI allergies are usually resolved for the babies, but eosinophilic esophagitis essentially is pretty permanent. So I'm going to now wax a little bit theoretical for the next number of slides. We think we're seeing this increase. We're pretty sure we're seeing this increase in food allergy. We had done one of the first studies looking at prevalence of peanut allergy in kids. Did that first study back in '97 when we had 1 in 250 kids with peanut allergy. Repeated that study over an 11-year period, went to 1 in 70, tripling. I didn't believe it. I was like, well, the methodology was the same, but something, maybe the cell phone changes or something like that caused this difference in the US population. But in the 2008 study, that was the 1 in 70, people started doing these studies elsewhere and with different methods that were like getting right to the patient and feeding them the food and seeing what happens. And the rates were the same in Canada, in the UK, in Australia. So basically westernized areas with some similar dietary approaches, we're seeing similar over 1% of kids with peanut allergy. So why the increase? It's clearly not genetics, because genetics doesn't change over 10 or 20 or 30 years. So the hygiene hypothesis is a big one. The immune system is supposed to be set up to fight infections, but we're well vaccinated. Well, maybe not always well vaccinated lately, but anyway, we're taking antibiotics. We're keeping ourselves. We have smaller families. We're not living on farms. So the immune system is all set up for parasites, and that's the IgE and eosinophilic response. So we messed ourselves up and haven't had a lot of evolutionary time. So attacking the wrong thing, autoimmune disease and allergies, attacking the wrong thing. The idea of not eating a food when you're a baby because it's an allergenic food, and if you're a prone to allergy family, you shouldn't eat it, that advice might not be the best advice, as I'll get to. A lot of times the nutrients in the diet are actually the immune beneficial things, and yet we're spending less time outdoors, maybe less vitamin D, some imbalances there as well. Inflammatory states of obesity, maybe messing things up. And then everyone's always like, well, what about the genetic modification of foods? I'm not so sure that that's an issue, but the style of the foods that we eat, peanut butter is an oily substance. It's almost like a built-in adjuvant. It's roasted, which makes the protein more stable for digestion, so get into the bloodstream. And also, by the way, many of the foods I eat are bacteria-free. Like my breakfast is a Fiber One bar, which I could sit in the drawer for a few years. And we have dishwashers. Like the microbiome thing, even within the foods, has changed. So there's this exposure theory that this very allergy-prone baby, right? That's the baby who has eczema, family history of allergy and stuff, but they usually get eczema first, and then they start developing food allergies, and then they end up later on with asthma and hay fever. But maybe the scenario is that exposure to this inflamed skin without eating the food is a trigger of sensitization and allergy. So if your advice is don't eat this allergenic food, then everyone around you is eating it, you're getting exposed to it on your inflamed skin, that could be counterproductive. The mouth, the oral exposure, is how oral tolerance gets kicked in. So looking at epidemiology studies, there were risks for peanut allergy of having eczema or using creams that contain peanut, but there were not risks for a baby eating peanut or for the mother eating peanut during pregnancy or lactation. And that observation was turned into a randomized controlled trial that made a lot of press and was in the New England Journal, where they took kids who were 4 to 11 months of age who had high risk for developing peanut allergy. They had bad eczema or already a food allergy to egg, and they were pre-tested because if they had strong positive tests, they were considered already allergic and weren't even part of the study. But if they had small positive or negative skin tests, they were randomized to eat peanut early or not. And sure enough, the group that was the avoidance group in the gray bars had high rates of peanut allergy 5 years later compared to the ones who were eating peanut early. So this ended up in a lot of worldwide press, and for countries that eat peanut butter and have high rates of allergy, recommendations started flying to get peanut into the diet earlier. And in the US, it's the National Institutes of Allergy and Infectious Disease Expert Panel report, made a guideline number 1, which basically copied this LEAP study, the study that I just described that was in the New England Journal, to pre-test a baby who has bad eczema, like they were in the study, and to, under physician supervision, get peanut into the diet in a supervised feeding scenario. But if they weren't super allergic already, if they had less eczema or just were a normal baby, the bottom line would be not to delay getting peanut into the diet. Peanut and peanut butter are choking hazards for babies, so it has to be done in a careful way.
Wasn't there an Israeli study?
Yeah, so that was this stuff. That was the Israeli studies. So what about a roundup on treatments? So this is a laundry list of potential therapies divided by some that would be for any food and some that are specific for particular foods. And I'm just going to walk us through some of these fairly briefly. So the background, to some extent, is what's your goal? Is your goal to make someone safe for an accidental exposure to some walnut or cashew in a cookie if they were avoiding it anyway, but there was a little bit there? Or is your goal to have egg salad sandwiches because we want to get rid of your egg allergy? Desensitization is a term that's used for saying that you need to be on this food to keep some threshold to it as a treatment. And I think you're familiar with that with like penicillin allergy. If someone's allergic to penicillin, you can gradually give them penicillin. You end up on their treatment dose. They're desensitized, and you get them through their course. But if you stop the penicillin and it's 3 months later and they need penicillin again, they're still allergic, you'd have to start all over again. They're dependent on taking it daily. Tolerance is what I was talking about with someone who's just not allergic to something. Their immune response is a healthy one, and they could eat the food whenever they want. So oral immunotherapy has been actually in the literature for over 100 years. It's giving gradually increasing amounts of the food, not just typically over one day, but over weeks and months. About 70 or 80% of people can be desensitized, meaning they can get onto some dose that's higher than what they could start with, and then stay on that to try to keep a higher threshold than they had before. We can get people up to gram amounts, which means eating regular food for some people. But doing this, especially for people who are very allergic, causes side effects, including particularly allergic reactions. So I'll get to that more. Pinna is being looked at as a pharmaceutical by a company that is in phase 3 studies, and we're waiting to see if the FDA is going to approve it or not. Under the tongue therapy is pretty remarkable in that it's milligram amounts that are put under the tongue daily. Side effect profiles, almost nothing, just takes a few seconds. And in the studies that have looked at it, you see someone going from reacting to like a 50th of a peanut to tolerating maybe a half to 1 peanut, which is pretty impressive for such a small amount with consistent exposure. There's a nicotine patch for peanut, so to speak, doing the same sort of thing with very low dose peanut on a patch on the skin that's worn 24/7. And similarly, with very small exposure, we're able to see some kids get an improvement in their threshold. It's not very robust. It actually may not be as robust as the sublingual I just mentioned, but it doesn't have much in the way of side effects. And that's also being looked at as a pharmaceutical in phase 3 studies that the FDA is going to have to contend with soon. We have injected therapies, I'm losing my voice. Some allergy shots are injecting people like with ragweed for ragweed allergies, pretty straightforward, and it helps. Bee sting allergy is curable. When people have a yellow jacket allergy, they start giving them shots of yellow jacket venom, and their anaphylaxis risk goes from 50% to less than 2%. But when people try doing that for peanut, they would react and have anaphylaxis to the shots. So one idea is to modify the protein itself, so you get healthy T cell responses and IgG responses without immediate allergic reactions. So we're looking at that. And then there's actually a DNA vaccine that makes peanut in your own body. Yes, we're injecting them to people right now, today, in our research unit. And that gets away from side effects and hopefully will be a more lasting treatment. And there are others. Biologics are being looked at as well. Omalizumab is anti-IgE antibody. It's been approved for asthma and for chronic hives. This in and of itself might change the threshold. Probiotics as a prevention, maybe more than a treatment, is being looked at. We even have been looking at traditional Chinese medicines. We've been looking at combination therapies using anti-IgE or omalizumab as a cover for giving oral immunotherapy so you'd have less side effects, and a variety of other combinations. So this summarizes some of the recent approaches, and there are others that I'm not talking about, but these are the ones that are most popularly being looked at. We have ongoing trials on now. At the top of this slide, I've just sort of summarized the robustness, the side effect profile. The oral immunotherapy is pretty robust, but there's a lot of side effects, the convenience aspect. So our hope is that in a few more years from now, we're going to have a lot of different strategies that we could offer any given patient, and even better, be able to personalize the therapies by doing some mechanistics first to see which is the best match for people and personalizing the approach. Now, on the potential downside, there was just recently in Lancet a systemic review and meta-analysis of the oral immunotherapy studies to peanut, only looking at the randomized controlled trials. And it's one of these things that we're going to have a lot of conversation with our patient about. One good approach is don't eat the food you're allergic to. Ask questions in the restaurant, read your labels. People get nervous anyway, but that keeps them from having a reaction. Don't eat it. Now, if you go and submit yourself to oral immunotherapy to peanut, then you have allergic reactions to the therapy itself. So what this study was bringing out was that compared to the placebo group, the group treated with the oral immunotherapy had basically a 3 times rate of anaphylaxis, a double the rate of use of epinephrine, and double allergic reactions compared to the group that was the placebo group. Now, usually, if you do a study and you're in the placebo group and you've had less side effects and less this and less that, it sounds like this drug wasn't a good idea. However, the treatment does increase threshold. So about 2/3 of the people had an increase in their threshold to peanut to about 2 or 3 peanuts from about less than half of a peanut. So pick your poison. Do you want to submit to this and have more allergic reactions than if you didn't submit to this? The trade-off is you have a decent chance of raising your threshold. But you could have a reaction to the treatment out of the blue on a Wednesday if you happen to get a virus. So is that less stressful or more stressful? So we're waiting to see what the FDA has to say about it. I alluded to the fact that we do a lot of studies here. We have a lot of clinical trials, basic science going on, epidemiology research, just about every aspect of food allergy. We have people looking into that in our group, and we do studies on adults as well. Our clinical practice isn't adults, but our research includes adults, especially when it's earlier in the studies. We usually start with adults. So we have about a dozen to 18 clinical trials going on at a time and different therapies, which I've shown you, and others that are coming. And so there's our contact information. If you have a patient who you think might be interested, you can just contact me if you want, and I'll get them in the right place. So I'm going to stop. Thank you again for this invitation and a topic that I guess is a little unusual. But
Question, that's great. The issue that you mentioned about exercise, I find fascinating, because we see exercise induced ischemic collapse all the time, particularly in watershed areas, with bleeding, diarrhea, etc., runners and such.
right.
We've also seen it with cocaine. We've also seen it with methamphetamines. Lately, I have seen with a couple of our pediatricians some cases of ischemic proctosigmoiditis associated with heterin.
With what?
Adderall,
Adderall.
methamphetamine,
Okay.
Desensitization. When you take a history from these kids, do you have a history of whether or not they are on Adderall? Because most of them are.
That's
on
a
Adderall.
that's a great. Now I'm going to look for that.
Well, this is because we
Have to do it in a careful way, as not to over.
Some of our
So
syndrome.
yeah, that's really so you think it changes splanchnic bed?
Well, we know that because we see people come in either with gross bleeding
Okay.
or they're anemic.
So
We see that.
So a theory, and it's a theory, is that the change in splanchnic circulation during exercise
Right.
changes the.
That's why I was interested in seeing how
Yeah.
many
So
the allergies are on methamphetamine, dexamphetamine.
yeah, that's a great. So so actually we've looked at. So we have a number of sort of like
Yeah.
birth cohort-y kind of studies, and we've looked at a different thing, which is antacid. So the thought of antacid medications reducing the digestion of the food, therefore making it more prone to have an allergic reaction, that has been shown in mouse models, and there have been some adult case reports, especially with fish allergy, where someone goes onto an antacid and starts to react to the food. But it's interesting. I'm sure that the use of these ADD medications is increased. And the question would be, is going on these associated with seeing some more, middle school aged allergies or some persistence of allergies? I'll get back to you because we should look into
Ask the
that.
question.
Yeah.
I had one father, when we took the kid off medication, told him to take off medication, say to me, what about the SATs? Resulted in a violent
Right.
response.
No, that's I like that idea. We're gonna have to start looking. Yes.
You mentioned that sometimes you give Epi when the reaction is mild, which you want to decrease the progression. So sometimes we get called from the infusion center and other patients on biologics where you're getting an IV iron infusion, which is more likely to do it.
Yeah.
They've gotten the antihistamines, they've gotten steroids. It is just a rash. What was your threshold for giving them iron?
So part of it is the observer. So when we instruct our patients, it's about first aid management of anaphylaxis. So this is someone who's in the restaurant or at school and things like that. We don't want them to go through progression because then they're giving epinephrine and they have poor circulation. I would think that in an infusion center you can monitor much better and you see if the heart rate is going up, if there's other signs that the reaction is worse. So you might, and also ER doctors, are sort of in our allergy world, we're like, why is the ER doctor giving us epinephrine already? Because it makes the person feel better, even if it's not because they're already in some kind of more extreme situation. So my answer has been fuzzy to you, which is, is it worthwhile to give it sooner? Maybe it is, but especially for first aid management, we're very liberal about giving it and not waiting for trouble breathing and such. Yes.
As you alluded to, patients who come in with these long breakouts, like the LCAT,
Yes,
stuff
LCAT.
like that. So that is essentially the body's natural reaction to foods, but that doesn't necessarily create an immune-mediated response. Right. there such a differential in the test results? Or someone has a reaction to like peppers?
Yeah, but you could also have, so one of the ones that you'll see more common in IgG testing are going to be the foods that are eaten more commonly, and milk and wheat will often show positive, and then you're often taking away a food that has other irritant effects, if you want to call it that, or intolerance effects. And also, there's one study that's like really funny to read, but they have the person go on a diet associated with the test results, and then the people have improvements in a whole bunch of different areas. But in this particular study, I can't remember the first author, but I don't want to look it up anyway. They actually mentioned about weight, and so like most of the people lost weight on the diet. So it's kind of like you just told people to stop eating junk food. They lost weight, now they feel better. It's sort of like was it the test that did that, or could you just told them stop eating cakes, cookies, candies, and ice cream? You might feel better. So there's a lot going on within those.
I guess what my curiosity was in those tests, why isn't there like a uniform reaction to all the?
It's a plated immunoassay. If you send the same blood sample 3 times, you'll get differences on that. And then again, it has to do with how much you're eating of certain foods too.
Scott, great talk. Great question. We all use a lot of EPI, certain patients at high doses. And what do you personally advise patients with oral allergy syndrome, as with regards to the foods that cause them itching? And do you think we, as the GI community that deals with high doses of EPI in certain patients, do we have to worry more about oral allergy syndrome patients?
Right now, I would not say to worry about it. I don't have enough data to say to worry about it. For particular patients, if you think you're seeing something, having that in the back of your mind, I think is helpful on a personal basis. But in terms of any sweeping things, are you aware of any data that would make you sweepingly say you have to worry about this?
One of the things that sometimes I tend to tell them, look, avoid the food just in case you really don't have much acid to break it down the way when you're not on the EPI. But I don't know.
It's an interesting question for
EE. For no good reason.
It's an interesting question for EE because there's seasonal EE, right? And then there's also you're bathing in the foods that are the oral allergy syndrome foods for people who have those allergies, and no matter what, you're coating the esophagus with it. So is that really contributing? And then if you have someone like that, you take them off milk and they're all better, then it's sort of like, well, wait, milk? That doesn't make So I think we need bigger studies, I think, to really look at that more carefully. In our 512 patient Consortium Food Allergy Research cohort, we did not see use of, and we had a pretty good number of kids who were using anti-reflux medications, and we didn't see an increased issue with them, but that was just one study. All right, thank you.